Hello. Rohini, Dr. Rohini.
Good morning, sir. I'm Rohini speaking, sir.
అమ్మా అనురాధ కానీ శ్రీకాంత్ గారు ఉంటే స్టార్ట్ చేద్దామా ఒకసారి రమ్మని వాళ్ళని.
ఓకే సార్. అనురాధ అంతా రాలేనట్టుంది సార్. ఇంకా రాలేదు సార్.
Good morning, sir. Good morning to all.
Good morning, ma'am.
శ్రీకాంత్ వచ్చాడా? ఓంకార్ స్టార్ట్ చేద్దామా? అనురాధ వచ్చింది కదా?
ఎస్ సార్.
మరి అనురాధ స్టార్ట్ చేయమను.
స్టార్ట్ చేయనా సార్?
అనురాధ చెప్పమను. అనురాధ స్టార్ట్ చేయమను.
Ma'am, shall I start the class, ma'am?
Good morning to all. Today, Dr. Rohini is presenting anesthesia management of Pheochromocytoma. Please start the class.
Okay, ma'am. Good morning, one and all. Today, I'm going to discuss about the anesthetic management of Pheochromocytoma. So, what is this Pheochromocytoma? It is a neuroendocrine tumor produced from the chromaffin cells, or it is a catecholamine producing tumor in the adrenal gland. Coming to the anatomy of the adrenal glands, these are the bilateral retroperitoneal organs located on the superior middle aspect of upper pole of each kidney, each weighing 4 grams. Left is somewhat greater than, which weighs somewhat greater than right adrenal. Right adrenal gland lies close to inferior vena cava and beneath the diaphragm and liver, whereas the left adrenal gland is located between kidney and aorta near the tail of pancreas and the splenic artery. So what are, I said Pheochromocytoma is a catecholamine producing tumor. So what are these catecholamines? So the catecholamines are categorized as dopamine, epinephrine, and norepinephrine are the main catecholamines. And in the process of mechanism of these catecholamines, there will be some metabolites produced, which are homovanillic acid, vinyl mandelic acid. These catecholamine producing tumors, these are produced from various cells like neural crests, chromaffin cells, and sympathetic ganglion cells. Tumor produced from neural crests is named as neuroblastoma, and tumor produced from the chromaffin cell, whether it is intraadrenal or extraadrenal, it is called as pheochromocytoma, and tumor produced from the sympathetic ganglion cells is named as ganglioneuroma. So overall, Complete catecholamine producing tumors are pheochromocytoma, paraganglioma, ganglioneuroma, neuroblastoma, cheodectoma, glomus jugular tumor. Coming to the history of pheochromocytoma, it was first recognized by von Frankel. It is a dusky colored tumor. Name is coined by Pick in 1912, and the successful surgery for the excision of tumor was done by Rox and Mayo. So coming to the pheochromocytoma, I said it is a neuroendocrine tumor of the medulla, reduced in the adrenal glands. It originates from the chromaffin cells along the paravertebral sympathetic chain extending from pelvis to the base of the skull. More than 95% are abdominal and 90% are in the adrenal medulla. They secrete excessive amounts of adrenal and noradrenaline. Rule of 10 in pheochromocytoma. They are 10% extra adrenal, 10% occurring children, 10% familial, 10% bilateral multiple, 10% recur, and 10% malignant, and 10% are discovered incidentally. So based on the production of metabolites from the tumor, there is large pheochromocytoma and small pheo. Large means it produces more metabolites within the tumor, and small means it will produce more catecholamines than the metabolites. And coming to the sporadic and familial pheo, the sporadic
Only rice. Yes. So he's also cooking, man.
In sporadic pheo, there will be more epinephrine. In familial pheo, the epinephrine will be more than norepinephrine. Paraganglioma, it produce more epinephrine. Cheodectoma and glomus jugular, norepinephrine. Ganglioneuroma, norepinephrine. Malignant myo, dopamine and HVA. Neuroblastoma, dopamine and mandelic acid. And these receptors on which catecholamines acts are alpha and beta adrenergic receptors, which will produce various clinical symptoms in pheochromocytoma. Coming to the alpha adrenergic receptors, there are alpha 1 and alpha 2 receptors, and the actions on alpha 1 receptors is vasoconstriction, mainly vasoconstriction, intestine relaxation, uterine contraction, pupillary dilatation, whereas alpha 2 receptors main mechanism of action will be they decrease the presynaptic release of norepinephrine, platelet aggregation, vasoconstriction, and decrease insulin secretion. Coming to the beta adrenergic receptors, there are three types of receptors: beta 1, beta 2, and beta 3. Beta 1 receptors, they increase heart rate or contractility, they cause lipolysis and increase the renin secretion. And beta 2 receptors mainly they cause vasodilatation, bronchodilation, and increase glycogenolysis. And beta 3 receptors, they increase lipolysis and brown fat thermogenesis. The clinical symptoms of pheochromocytoma, hypertension is the most common symptom, occurs in the age gap of 30 to 100 years of life, equal in with the males and females. If investigate only if there is clinical suspicion of signs or symptoms, if there is any severe hypertension or hypertension crisis, refractory hypertension, which is produced by more than 4 drugs. If hypertension is present at a young age, that is less than 20 or older age more than 50, adrenal lesion found on imaging. Coming to the clinical symptoms, the main 5 P's, that is pressure, that is hypertension. 80% of the most common is headache, next perspiration, palpitation, pallor. And last one is paroxysms, the spells means spells. The classical triad of pheochromocytoma is pain, headache, perspiration, palpitations. Lack of all three virtually exclude diagnosis of pheo. Hypertension is the most commonest presenting complaint. Coming to the paroxysmal spells in pheochromocytoma, these occur for 10 to 60 minutes duration. Frequency include daily, they occur daily to monthly. They're spontaneous and they're precipitated by the activity that displaces the abdominal contents, like diagnostic procedures, contrast, drugs like opioids, beta unopposed, beta blockade, anesthesia, induction, histamine, glucagon, metoclopramide, and they are precipitated by the strenuous exercise, movement that increases intra-abdominal pressure, like lifting or straining, and by the micturition. Symptoms paroxysmal symptoms depend upon the relative proportion of epinephrine, norepinephrine, and by the excessive secretion of epinephrine dopamine. Symptoms that occur due to epinephrine secretion are headache, profuse sweating, palpitations, apprehension, often with a sense of impending doom, pallor and flushing due to peripheral adrenergic response. And the symptoms due to dopamine, they include nausea and vomiting due to vasodilation in the gastrointestinal tract. Hypotension is a rare symptom. It occurs in many cases because of ECF contraction and loss of postural reflexes due to prolonged catecholamine stimulation and tumor release of adrenomedullary. Cardiac manifestations in pheochromocytoma include sinus tachycardia, bradycardia, supraventricular tachycardia, ventricular atopics, and ventricular tachycardia. Catecholamine-induced increased myocardial oxygen consumption and coronary vasospasm. Causes angina or myocardial infarction, cardiomyopathy, mostly hypertrophic cardiomyopathy, dilated cardiomyopathy, and congestive cardiac failure with myocarditis, concentric hypertrophy or asymmetrical hypertrophy, and rarely sinus node dysfunction. And neurological manifestations, they include hypertensive encephalopathy, which is presented as altered mental status or focal neurological consists of seizures, stroke due to cerebral infarction or embolus, and intracerebral bleed. And metabolic symptoms, they include hypercalcemia, mild glucose intolerance occurs due to suppression of insulin secretion and increased glycogenolysis. Epinephrine causes stimulation of insulin release through beta-2 adrenoreceptors. This is offset by the effects of circulation norepinephrine, polyuria, and lipolysis. And syndromic pheochromocytoma, the von Recklinghausen's familial paraganglioma and familial pheoid cell tumor, and others include tuberous sclerosis, Sturge-Weber, ataxia telangiectasia, Carney's triad, include pheochromocytoma, gastric leiomyoma, and pulmonary chondroma. Coming to the diagnosis of pheochromocytoma based on biochemical and localization, 24-hour biochemical tests include the urinary collection 24 hours, which will detect the vinyl metabolites in the urine. Positive results, more than 2 to 3-fold elevation in 24-hour urinary collection of catecholamines. And coming to the total metanephrines, there will be more than 1.2 micrograms. And coming to the vinyl malic acid, there will be more than 3-fold elevation. They are detected by the high performance liquid chromatography. Sensitivity is increased if 24 hours urine collection began at onset of paroxysm, and serum creatinine is measured for all the collections of urine to determine the adequacy of collection. These are the sensitivities and specificities of metanephrines and catecholamines. There will be some false positive tests because of some medications or drugs we'll use, like tricyclic antidepressants, MAO inhibitors, levodopa, methyldopa, labetalol, propranolol, clonidine, illicit opioids, amphetamines, cocaine, ethanol, sympathomimetics. So what we'll do is we'll hold these medications for 2 weeks, and because of major physical stress like hypoglycemia, stroke, and rise recipe, there may be some false positive results. And plasma catecholamines, if plasma total catecholamines are more than 2000 picograms per milliliter, we can confirm it as a pheochromocytoma. And in this case, false positive include if there are any diuretics used or if the patient is a chronic smoker. And coming to the suppression or stimulation testing, clonidine suppression, usually they decrease the catecholamines. Unlike normal people, pheochroma patients won't suppress their plasma norepinephrine with clonidine. Glucagon stimulation, they may precipitate the hypertensive crisis. But in pheochromocytoma patients, they will have a more than 3-fold elevation increase in plasma norepinephrine with glucagon. Localizational imaging, they are mostly 90% adrenal. Extra-adrenal sites, they include organ of Zuckerlander, bladder, myocardium, mediastinum, carotid, and glomus jugular bodies. And CT abdomen, it is 93 to 100% more sensitive. MRI more sensitive than CT for extrarenal pheochromocytoma, and MIG scan sensitivity is 90%, whereas specificity is 95%. This is a MRI which shows a pheochromocytoma in the adrenal gland. This MIG scan, it is a I-123 or 131 iodine labeled methiodobenzyl gonadine saved for cases where pheo diagnosed biochemically but no tumor on CT or MRI. MIG catecholament pickets are taken up by the tumor. We will inject MIG scan at 24 hours, 48 hours, and 72 hours. There are some false negative scans because of the drugs like labetalol, risperidone, and tricyclic antidepressants, phenothiazines. So we have to hold these medications for 4 to 6 weeks prior to the scan. This is a MIG scan photography showing the pheochromocytoma. Coming to the management of pheochromocytoma, preoperative, operative, postoperative, and what we'll do in case of pregnancy. Mostly the mortality for the existence of pheochromocytoma is about 24 to 50% because of the hypertension crisis, arrhythmias, MI stroke, and hypertensive shock. Currently, the mortality is reduced very to 0 to 2.7% because of the preoperative management we are using, like preoperative preparation, alpha blockade, and the new anesthetic techniques like use of various anesthetic agents and intraoperative monitoring. So we are performing the case of pheochromocytoma. We need a very experienced and coordinated team, including endocrinologist, anesthesiologist, and surgeon. Preoperative workup, before we have to perform some lab tests, a complete blood picture, electrolytes, creatinine, INR, PTT, chest X-ray, ECG, and echo. And preoperatively, we have to start them on some combined alpha plus beta blockade or Metyrosine or calcium channel blocker to prevent the hypertension. Combined alpha plus beta blockade, they include in giving drugs at phenoxybenzaimine or selective alpha blocker like Preoperative or propranolol, Metyrosine and calcium channel blocker like nicardipine. We have to start at least 10 to 14 days before the surgery. Coming to the mechanism of action of phenoxybenzaimine, it is a drug of choice which is usually prescribed. It covalently binds the alpha receptors. We have to start phenoxybenzaimine 10 mg BID for oral. Then we have to increase by day 2 by 10 to 20 milligrams per day. So we have to increase until the BP controls and no more the paroxysm takes place. And we have to maintain at least 40 to 80 mg per deciliter. So in case some patients may need more than 200 mg. Phenoxybenzaimine, side effects with phenoxybenzaimine, they cause orthostasis with dosage required to normalize BP, reflex tachycardia. They'll cause periop hypotension or shock, unlikely to respond to the pressor agents. And presynaptic inhibition of adrenergic control, thus leading to an increase in beta adrenergic outflow. Thus, beta blockers have to be given along with the phenoxybenzaimine. For the evaluation of alpha adrenergic blockade, there's Roisen's criteria. That is, arterial blood pressure is less than 160 per 95 mm of Hg in the last 48 hours prior to the surgery. Recommended to measure in stressful environment. Mild orthostatic hypotension indicates optimal alpha adrenergic blockade, but not less than 80 by 40, BP of 80 by 45 mm of Hg. In ECG have to free of ST changes for more than 2 weeks, and ventricular atopics should be less than 1 over 5 minutes. Coming to the beta blockade, it is used to control reflex tachycardia and prophylaxis against the arrhythmias during surgery. It have to be started only after the effective alpha blockade because it may precipitate the hypertension. If we suspect any congestive heart failure, dilated cardiomyopathy, we should start in low doses. The dose of the propranolol we should start at 40 mg and gradually increase to depending upon the heart rate. maximum dose up to 480 mg per day in divided doses. Intravenously, we can give 1 to 2 mg bolus. Propranolol side effects they may cause cardiac failure, bronchospasm, and the oral bioavailability is only 25% because of extensive first pass metabolism. And atenolol, which is a selective beta 1 blocker, we can start with 50 to 100 mg, up to maximum dose 300 mg, whereas intravenously we can inject 2.5 to 10 mg per day. Coming to the esmolol, it is a selective beta 1 for rapid intraoperative BP control. IV bolus dose of esmolol is 250 to 500 microgram per kg per minute coming to the IV, whereas in case of infusion, 25 to 250 microgram per kg per minute. Labetalol, it is a mixed alpha plus beta blocker. Dose of labetalol is 50 to 200 mg per day. Intravenously, we can inject to 0.25 mg per kg. But this is not used as sole drug due to unpredictable control of BP. If BP still doesn't not subsided despite of this alpha and beta blockade, we can add prazosin along with phenoxybenjamin. Prazosin, it is a competitive selective alpha 1 blocker. T half is about 2 to 3 hours, and dosage of prazosin is 1 to 5 mg per oral. But side effects of prazosin, it will cause postural hypotension, reflex tachycardia. No beta blockade is required because it is not routinely used as it is incomplete alpha blockade and is used for the more for long-term treatment. Other selective alpha blockers are terazosin, doxazosin. And calcium channel blockers, we can use diltiazem 60 to 120 mg per day, maximum up to the dose of 360 mg. Its half-life is 3 to 5 hours, and side effects they cause bradycardia and exacerbates cardiac failure. Nifedipine dose is 30 mg per day, maximum up to 360 mg. T-half is 1 to 2 hours, and it causes hypotension, peripheral edema. AC inhibitors like ramipril. Avoid diuretics as already ECF is contracted. Nicardipine, it is started 24 hours prior to few weeks to control BP and to allow the ECF restoration. And after intubation, we can start IV nicardipine starting at 2.5 microgram per kg per minute, to adjust the systolic blood pressure. And it is stopped prior to the ligation of tumor venous drainage. And tachycardia, to treat tachycardia with concurrent IV esmolol. Advantage is peri-op hypotension may still respond to pressor agents as opposed to those patients who are completely alpha blocked. These medications should be given on the morning of surgery. For the peri-op hypertension, we'll give IV phentolamine, which is short-acting non-selective alpha blocker, or IV nitroprusside. For peri-op arrhythmias, IV esmolol. For hypotension, IV it is treated with IV crystalloid or plus colloid. If for the treatment of hypertension crisis, they include IV phentolamine, nitroprusside, esmolol, and labetalol. We can do. Coming to the metyrosine, it is a synthetic inhibitor of tyrosine hydroxylase. The dose of metyrosine is 250 mg 4 times per day, maximum up to 1 gram. But because their side effects of metyrosine, they include sedation, extrapyramidal side effects, and diarrhea, nausea, vomiting, anxiety, renal or colic stones, and galacturia. It is alone may insufficiently control BP, but reported hypertension crisis during the surgery of pheochromocytoma. So it's restrict use to inoperable or malignant pheochromocytoma, so as to exempt to alpha plus beta blockade or other pre-op preparations. Coming to the operative room, admit the patient before the night and give him the IV saline. Make sure that there is arterial and EKG monitor and CVP line. If the patients have any congestive cardiac problems like congestive heart failure or any coronary artery disease or low ejection fraction, consider Swan-Ginch catheter insertion, pulse of SpO2 probe, ETCO2 temperature monitoring. And pre-op medications include anxiolytic sedative like benzodiazepine. They help to decrease the catecholamine release. Opioids or morphine is preferably avoided as it causes histamine release. Fentanyl are safe to provide. Pre-medication, atropine or glycopyrrolate to be omitted because they cause tachycardia. Droperidol is an anti-emetic which blocks the alpha etonoreceptor and inhibit the catecholamine uptake and promotes the catecholamine release. Anesthetic technique, mostly general anesthesia is preferred. Coming to the regional anesthesia, if the tumor is located between mid to low thoracic regions and combined regional and general anesthesia. The most commonly preferred is combined regional and general anesthesia technique. Here, although the regional anesthesia protects against the stress of surgery, it cannot prevent the catecholamine surges due to tumor manipulation. In extensive sympathetic blockade, severe hypotension occurs after the tumor removal. Coming to the induction, essentially important to give induction agents slowly along with close monitoring of heart rate and arterial pressure. Thiopentane or propofol is widely used. Etomidate, it causes pain or involuntary movement. Ketamine is not recommended because of high pressures. Multimodal analgesics like benzodiazepines plus opioid plus induction agents are preferred. During intubation, in order to decrease the pressor response, we can inject 2% lignocaine 1 to 1.5 mg per kg or give esmolol 50 to 100 micrograms per kg per minute. And during laparoscopy, usually the catecholamine levels were increased normally. In normal people, they'll increase to 200 to 2000 picograms, whereas in pheochromocytoma, there will be double fold in increase like 2000 to 20,000 picograms. Neuromuscular blockade, most commonly we use non-depolarizing neuromuscular blockade like drug of choice is vecuronium, and succinylcholine is avoided as it causes fasciculations and rise in intra-abdominal pressure. Atracurium and mivacurium best avoided due to release of histamine, whereas cisatracurium and rocurium are safe as they're cardiostable and least they produce less histamine. Maintenance, inhalation agent like isoflurane is used extensively because it does not sensitize the myocardium to catecholamines, whereas halothane is not used as it is erythemogenic, and we can use sevoflurane also used successfully. In operative room, we have to keep these drugs essential before performing and before starting the case of pheochromocytoma, like IV phentolamine, nitroprazide, esmolol, and other alternatives we can use are magnesium sulfate 40 to 60 mg per kg, bolus followed by 2 grams per hour. If there is a very high uncontrolled blood pressure despite of all these medications, we'll immediately ask the surgeons to stop the procedure. Ligation during the surgery, after the ligation of the adrenal vein, there will be sudden hypotension, which should be treated with the crystal plus colloid infusion. They may need dopamine, noradrenaline, and phenylephrine infusions, and aim for CVP 12 or wedge pressure 12. Inotropes may not work. Adverse perioperative effects, depending upon if there is large tumor size, there is prolonged duration of surgery or increased levels of perioperative urinary catecholamines and catecholamine metabolites. Laparoscopic adrenalectomy is used if the tumor is less than 8 centimeters or slow CO2 insufficient but not more than 12 mm of HCG. Postoperatively, the patients may need post-op ventilation or ICU stay depending upon the hemodynamic status, preferably ICU stay for 24 hours, and postoperative hypoglycemia due to disinhibition of B cell suppression, that is because increased insulin secretion. So we have to supplement glucose at the end of the surgery. Most cases can stop all the BP medications postoperatively because they may cause hypotension, which can be treated with the crystalloid. Hypertension free, that is 5 years, 74% in 5 years, and they are 45% for 10 years. And 24-hour urine collection should be done 2 weeks postoperatively, and we have to survey the urine collections at least for 10 years, or lifelong follow-up should be there. 5 years non-malignant pheochromocytoma, they give 5 years survival, whereas malignant will be less than 50%. If the tumor is large, unresectable, or it is malignant pheochromocytoma, in order to reduce the blood pressures, we'll use alpha blockade with selective alpha-1 blockades like prazosin, terazosin, doxorubicin are the first line. Pheoxybenjamin, it includes more complete alpha blockade, beta blocker, calcium channel blockers, AC inhibitors, and nuclear medicine treatment like high dose iodine 131 mg or indium octreotide depending on the mix scan or octreo scan pickup. Sensitize the tumor with carboplatin plus 5-fluorouracil. In case of pregnancy, the pheochromocytoma, which has very grave prognosis, mortality is maternal is 48%, whereas coming to the fetal mortality is 55%. It is diagnosed with for urine collections and MRI. There will be no stimulation test, no mix scan, never spontaneous labor, and in first and second trimester, we can give phenoxybenjamin plus beta blocker preparation and laparoscopical resection of the tumor. Coming to the third trimester, phenoxybenjamin beta blockade. 37 weeks, we have to terminate the pregnancy. Cesarean section followed by the tumor resection. Conclusion: long-term outlook is very good, managed by an experienced team of anesthesiologist, surgeon, endocrinologist, and cardiologist. Principles of anesthetic management, they include good adrenergic blockade preoperatively, vigilant intra-op monitoring and treatment of hyper or hypotension, post-op ICU care, and antihypertensives for a prolonged period. Thank you.
Thank you, Rohini.
Thank you, ma'am.
Questions from seniors. Sir, any questions? Dr. Ramnaprasad, sir?
ఆయన లైన్ లో ఉన్నాడా?
ఏమో ప్రెసెంట్ అయి ఉన్నారు. ఓకే సార్, ఎనీ క్వశ్చన్స్? మోహన్ సార్, రాణి మేడం, ఎనీ సీనియర్స్? శ్రీకాంత్ సార్, ఓంకార్, శేఖర్ సార్, మంజులా మ్యామ్.
How many cases you have done pheochromocytoma, Rohini? Rule of 10 is good to remember.
Sir, I have seen only one case while I'm doing my postgraduate in Guntur Medical College, sir. Till now, I did not see any other cases. Only that too for short period of time I have there for the case, sir.
Srikanth, Shekhar, experience చెప్పరా?
I have seen one case only.
చైతన్య, నువ్వు ఎన్ని కేసులు చేసావమ్మా?
Good morning, sir. Sir, 2 cases చేశాను sir.
ఏంటి 2 కేసులు?
Yeah, sir, 2 yeah, 2 left.
రాణి మేడం, మీరు ఎన్ని కేసులు చేశారు? సరే, శ్రీకాంత్ లైన్ లో ఉన్నాడా?
సార్ సార్ రీసెంట్ గా కేసు చేశాను సార్. అది ఓంకార్ చేశాడా అరవింద్ చేశాడా గుర్తులేదు. బట్ ప్రియాప్ అది చూసాను సార్. ఎండోక్రైన్ వాళ్ళు ఎవాల్యుయేషన్ అది చేశారు. ఈ ఆప్టిమైజేషన్ అది పెట్టుకొని 2 weeks అప్పుడు చేశాను సార్. ముందు యాక్చువల్గా మన్మధరావు సార్ డైరెక్ట్ గా అడ్మిట్ చేసి పిఎస్సి చేసేస్తాను అన్నాడు. ఆవేశపడక బాబు, ఇది అలా చేసే కేసు కదని సో ఆయనకి సర్ది చెప్పి డిశ్చార్జ్ ఇప్పించి మళ్ళీ 2 weeks తర్వాత అడ్మిట్ చేశాను సార్. అరౌండ్ వన్ ఇయర్ బ్యాక్ అలా ఒక కేసు, అంతకుముందు ఒక 2 years ముందు ఒక కేసు, అలా రఫ్గా 3-4 cases అలా అయ్యాయి సార్. ఇయర్ కూడా తగులుతుంది. అరవింద్ చేశాడు, గాయత్రి ఒకసారి.
రోహిణి,
Sir,
what are the important investigations you should not miss?
urinary catecholamines and plasma catecholamines and urinary metabolites, sir. Mainly
What is classical triad of pheochromocytoma?
Madam, triad, it includes headache, perspiration, and hypertension, ma'am.
Headache and palpitation and diaphoresis, episodic nature of.
Yes, ma'am.
And in the name only pheochromocytoma means pheo means dark, chromo
Yes.
means color, cyto means cell, and oma means tumor.
Tumor.
So that's why is pheochromocytoma.
Yes, ma'am.
So in the echo, what are the things we have to say in acute and chronic pheochromocytoma? I mean problems.
Cardiac, they cause cardiomyopathies, they cause diastolic dysfunction and congestive cardiac failure, concentric hypertrophy, and they may also cause ventricular ectopics.
కాదు తప్పనండి శ్రీకాంత్, మనం ఇవేనా చేస్తాం మామూలుగా రొటీన్ కేసు. లాస్ట్ టైమ్ ఐ రిమెంబర్ discussing Chaitanya, do you remember last time when we had a cases here, we had a lot of discussion regarding what are the important issues which we missed it.
Sir?
లాస్ట్ టైం మనము ఒక 2 ఇన్వెస్టిగేషన్స్ మిస్ అయితే మళ్ళీ చేయించి మళ్ళీ చేసాం కదా కేసు.
I think sir ante urinary catecholmens and ade 24 hours ive sir abe chesam sir,
Because from what we used to get in the OT when I was in Nizam's around 98 or 97, it was very hectic cases. If you think about the pheochromocytoma, at that time the cases were little more. Now it's come down very drastically. I do not know the reason. Maybe we are not in the center like that.
అప్పుడు ఇన్వెస్టిగేషన్స్ అయితే ఇదే చేయించారు సార్. ఎండోక్రైన్ కూడా అవే సజెస్ట్ చేస్తారు, అంటే ప్లాస్మా క్యాటకాల్మెన్స్, యూరినరీ క్యాటకాల్మెన్స్, మెటబలైట్స్ అండ్ ఆప్టిమైజేషన్స్ 2 weeks డిశ్చార్జ్ చేసి 2 weeks తర్వాత.
That's more important. Yeah.
Sir, good morning, sir. Sorry, just was busy with our MRI, sir. Sir, I want to ask about a case, sir. Rohini madam.
Sir.
Yesterday we saw a case. Do you remember that?
Yes, sir. Yes, sir. Obese patient, hypothyroid.
Gurtunda meeku?
History.
Sir.
OSA.
It's a case, 65-year-old, not 55-year-old male, came for MRI brain, and he's a pheochromocytoma patient, uncontrolled hypertension, uncontrolled pressures with sleep apnea syndrome, weighing 135 kgs, and hypothyroidism post PTCA. He came for MRI, sir. So I want any student to tell me how should we plan for MRI for this patient. Anyone, please.
What are the main highlighting the problems, Omkar?
Sir, uncontrolled pressures, and he's having what you call continuously he's having what you call that burp within for every 5 minutes and all. He'll have one big episode of almost he's having a vomiting like that, and because of high pressures he's having profuse sweating also, sir, intermittently. His 2D echo was done, which is on normal only, sir. And the problem is he want to get that surgery done for which MRI is required, but he's unable to what you call lie supine position for around 5 minutes also. So we are unable to do MRI. So he came for anesthesia. So I want anyone to comment. How can we proceed with this case?
Without you can give responding time ఎంత ఉంది? Sorry, ఎవరు మాట్లాడతారు?
Are you asking the plan for MRI for anesthesia for MRI or anesthesia for surgery?
MRI, sir.
As these days I am outstanding surgeon, see outstanding anesthetist, so I am asking about MRI.
Sir, you can give etomidates, sir, with nasal CPAP.
Sir, with the MRI we cannot take CPAP inside, sir. Hello.
Oh, okay, sir. With oxygen mask.
We tried that, sir. Immediately we are putting him in supine position. He's getting SOB and his saturations are dropping to 84 or something with the 15-liter oxygen, sir. This happened within hardly 2 minutes.
బయట వితౌట్ ఎంఆర్ఐ సూట్లు కాకుండా బయట పడుకోబెట్టి స్టడీస్ నుంచి కాసేపు ఏమైనా ట్రై చేశారా ఓంకార్?
సెడేషన్ ఇవ్వలేదు సార్, కావాలని సుపైన్ పొజిషన్ లో పెట్టాను వితౌట్ ఆక్సిజన్. ఆయన 2 minutes కూడా ఉండలేదు సార్, వెంటనే లెగిసిపోయాడు. మళ్ళీ కూర్చోబెట్టి స్టెబిలైజ్ చేసి మళ్ళీ కావాలని ఆక్సిజన్ పెట్టి మళ్ళీ సుపైన్ లో పెట్టాను. మళ్ళీ 2-3 minutes లోనే మళ్ళీ లెగిసిపోయాడు ఆయన.
మరి ఏం చేసావు?
ఉంది సార్, ఉంది. ఈ రోజు కానీ రేపు కానీ వస్తుంది. సో ఐమ్ వెయిటింగ్. So my plan is to give him minimal sedation, put an airway. That's what we can do. Large size airway and
nasopharyngeal airway పెడదామనా?
You can use an NPA, I think. You can use an
NPA nasopharyngeal airway పెడితే బెటర్ కదా?
Nasopharyngeal will be good, sir. It will be helpful, but we have to see, because nasopharyngeal airway will increase my anesthesia dose, which is very tough to that patient because he's very obese. Already I need to give a bit of more dose to knock him out, and with nasal airway and all, I think he won't cooperate.
Nasal airway is actually more comfortable.
Nasal airway is more acceptable than the oral airway kada?
Yeah,
more acceptable, but the thing is while passing, I don't know how much he will cooperate or not.
The thing is, if he is lying down, the main problem must be the
airway obstruction.
Tongue. Airway obstruction.
Yeah.
That we are countering with the nasopharyngeal airway, which will
నార్మల్ గా నిద్ర పెట్టేప్పుడు ఏం చేస్తాడు ఓంకార్ అతను?
Lateral position, sir, head up position.
Yeah, he will lie in his lap. That's a defense mechanism, sir.
కార్డియాక్ స్టేటస్ ఏముంది?
అదే సార్, ఎప్పుడు 7 years back or 6 years back I think he had PTC, post PTC.
దానికి ఎజెక్షన్ ఫ్రాక్షన్ ఎలా ఉంది అని, ఎజెక్షన్ ఫ్రాక్షన్ ఎంత ఉంది ఇప్పుడు?
రీసెంట్ 2 months బ్యాక్ జరిగింది సార్, షోయింగ్ 64%.
అంటే ఒకసారి అదొకటి చూస్తే గిన, అంటే లంగ్ కాంపోనెంటా లేకపోతే హార్ట్ కాంపోనెంటా ఈజ్ మేకింగ్ ఈజ్ నాట్ ఏబుల్ టు లై డౌన్ సుపైన్? అది కదా పాయింట్.
That's the obesity component, sir. Actually,
I told 135 kgs large tummy whenever he's going on supine position. దాని వల్ల ఆయన ప్రాబ్లం ఉంది సార్. I don't think it's cardiac.
It's a OSA component, sir.
Yeah, he's already having CPAP.
Hello, Omkar.
Madam, good morning, madam. Chepandi, madam.
Morning. Omkar, I think patient anta obese and even if you give minimum sedation, I don't think throughout MRI he'll maintain saturation. He said with 10 or 15 liters oxygen also he was desaturating very quickly. Yes, so maybe difficult. If possible, maybe HFNO use cheyali leda MRI compatible equipment petukoni under anesthesia, under GA, proper ga secure airway and do it. That's the safest method, I think.
సేఫ్ ఏంటంటే ఇంటిబేట్ చేయడం, ఎంఆర్ఐ అయిన తర్వాత బయటకు వచ్చి ఎక్స్పెక్ట్ చేసి ఎన్ఐవి పెట్టడం.
Yeah, that is a solution, sir. And I have a doubt whether the MRI can be done in a lateral position, in which he is more comfortable.
Yeah, Shekhar, actually we tried that also, Shekhar, but it's not helping us.
Okay.
Even in lateral position also, we cannot give him head up position. So even that is, it is making us a bit difficult. He's not cooperating for that also.
Okay.
So I feel
MRI, how much time it will take?
Madam?
Yeah.
MRI, how much time?
MRI ideally it will take around.
It will take 40 minutes, madam.
But 40 minutes means better to control airway and do, and after
Yeah, madam. We have to
my
check
opinion.
today or tomorrow I will come. Once he will come, we'll see what I can do. But nasal airway, I think it's the best option. But
Oh.
Omkar, intubation is best option.
sir.
Omkar, for 20 to 40 minutes, for 20 to 40 minutes, don't take chance because in the middle you'll have to run inside. If you don't intubate pre-procedure, you better have another person helping for you, and you may have to run inside in between. Once they start desaturating, they'll desaturate very quickly and can go into bread. I'm not frightening you, but that's what usually happens with obese patients.
Baseline ABG change, Omkar.
Sir?
Baseline ABG change.
అదే సార్ అంటే అది హాస్పిటల్ అడ్మిటెడ్ కేసు కాదు సార్ డైరెక్ట్లీ ఇంటి నుంచి వస్తున్నారు ఇఫ్ ఇట్ వాస్ హాస్పిటల్ కేస్
తప్పేముంది బయట నుంచి వచ్చినా సరే మనం వీ కెన్ డూ దట్ ఏబీసీ చేయించవచ్చు ఓపీలో
సార్ అక్కడ
ఓపీలో ఏబీసీ చేయించవచ్చు కేర్ లో అయినా ఎక్కడ సరే చేయించవచ్చు ఓపీడీలో
అదే సార్ ముందు కౌన్సిల్ చేయాలి ఏదో ఈస్ అన్ అడ్వకేట్ అండ్ ఈస్ హ్యావింగ్ మెనీ కాంటాక్ట్స్ ఐ థింక్ ఐ యామ్ గెటింగ్ కాల్స్ ఫ్రమ్ సమ్ sub inspector, somebody, some collector, somebody also called me. So once
VIP means Omkar, VIP means you have to take care more.
I think you have to warn them if required. He may have to get admitted to hospital after the procedure if required. That's what you have to mention beforehand.
So basically, he went for this MRI thrice, madam. They were unable to do. They have done CT 6 months back, and it's not fruitful. And now he wants to get his CT done by hook or crook.
That's why I explain everything. I'm sure even if they say, okay, if it can be done without any problem, even under GA, they'll be very happy, properly and safely. If you do without it and get problem in the middle and abandon the procedure, they'll think again it's failed. So you have to take precautions from before and explain to them and then do it.
With the written consent.
In-house MRI ఎక్కడ లేదా సార్ ఫెసిలిటీ నాట్ ఇన్ ఎనీ
అన్ని హాస్పిటల్లో ఉంది ఎందుకు లేదు
దట్స్ ఎ బెటర్ ఆప్షన్ కదా సార్ ఇన్స్టెడ్ ఆఫ్ ఫిజియో
కరెక్టే బట్ అది ఓంకార్ ఏం చెప్పంటే వాళ్ళకి అట్లా కాదు విజయ వాళ్ళకి బిజినెస్ పోద్ది కదా వాళ్ళు అలా చెప్పకూడదు వాళ్ళు ఏం చెప్పాలంటే సార్ ఈ కేసు ఇంటిగ్రేట్ చేసి చేయాలి సార్ మరి పోస్ట్ స్టాప్ ఉండాలి ఎవరైనా ఒకరు ఉండాలి అవసరమైతే అడ్మిషన్ ఉంది బేస్ లైన్ ఏబీసీ కావాలని ఒకసారి చెప్పేస్తే వాళ్ళకి టెక్నీషియన్ కి వాళ్ళు మాట్లాడుకుంటారు ఎందుకంటే వాళ్ళు ప్రతి హాస్పిటల్ వాళ్ళు బయటికి మాట్లాడేది వేరు లోపల మనసులో ఉన్నది వేరు ఉంటుంది ఎవరికైనా సరే
ఈ దెబ్బకు బాగా పాపులర్ అయిపోతాం ఇంకా నువ్వు
Sir, my question to madam is any baseline investigations which I have to get it done for giving sedation like ABG, anything else, sir? 2D echo, anything else?
అక్కడే చేశారన్నావు కదా
సార్
ఏబీజీలో నీకు మాక్సిమం వస్తాయి ఏబీజీ ఎలక్ట్రిక్స్ లో మాక్సిమం కవర్ అవుతుంది నువ్వు క్రియాటిన్ ఆల్రెడీ చేస్తారు ఎట్లాగో ఎంఆర్ కాంట్రాస్ట్ ఇస్తారు అనుకుంటే
నార్మల్ అది 1.2 అలా ఉంది 1.1
పిఎఫ్టీ ఏమైనా చేశారా
సార్
పల్మనరీ ఫంక్షన్ టెస్ట్ ఏమైనా చేశారా
పిఎఫ్టీ మధ్యం చేయలేదు సార్ ఆల్రెడీ ఆ సిపాపియాకి అంటే ఏదో చూపిస్తున్నారు వాళ్ళు పల్మనాలజిస్ట్
ఇక్కడ ఒక పేషెంట్ ఉంది 170 kg లేడీ
But obviously, even with sedation, also you will face the similar challenges kada Omkar asla. Like autonomic disturbances, fluctuating pressures, everything you will have.
I I said I counsel them that there are too many risk factors and we can try, but to a limited extent only. After that, we cannot go further. So we have to see.
నా సజెషన్ అయితే ఎక్కడైనా ఇన్హౌస్ ఎంఆర్ఐ ఉన్న చోట ప్రశాంతంగా చేయించుకోవడం బెటర్. నాట్ ఇన్ విజయ డెఫినెట్లీ.
అది అయింది సార్. We asked to go to Vijaya only. So once we are doing the case, I will post the details in the group again.
ఆల్ ది బెస్ట్.
మనకు ఇస్ దేర్ మనీ హాస్పిటల్స్ లో ఎక్కడైనా సరే ఎంఆర్ఐ అయినా సరే ఎంఆర్ఐ కంపాటబుల్ మిషన్స్ ఉన్నట్లేవు.
లేదు సార్, లేదు. ఎంఆర్ఐ కంపాటబుల్ ఎక్విప్మెంట్ ఎందులో లేదు సార్.
తెలిసి అపోలోలో ఉంది.
But at least until we'll have faster access to ICU or ER and anything like that.
That is true. That is true.
అసలు సాచురేషన్ మానిటర్ కూడా విజయ మెడికల్ లోనే ఉన్నట్టుంది సార్ నాకు తెలుసు.
యా దట్స్ అంతే, అక్కడే ఉంది.
ఎంఆర్ఐ కంపాటబుల్
ఐ థింక్ మెడికల్ లో కూడా ఉన్నట్టు
ఉంది 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 అన్ని చోట్ల
మెడికల్ లో ఉంది.
మొన్న వచ్చింది సార్ హెచ్సిజి నుంచి అనుకుంటాను. అదే ఏదో మానిటరింగ్ అవ్వదు అని చెప్పి పంపించారంటే.
రోహిణి కేసు డిస్కషన్ అయిపోయిందా
సార్?
మీ డౌట్స్ కానీ మీ క్లారిఫికేషన్స్ కానీ ఏమైనా ఉన్నాయమ్మా మీ కేసు గురించి, ఫియోక్రోమోసైటోమా గురించి? చాలా కాలం నుంచి చేసి.
ఎస్ సార్, అంటే కేసు ఎప్పుడు అది చూడలేదు సార్. చూస్తే నాకు కొంచెం ఇంకా బాగా మంచి ఐడియా వస్తుంది అనుకుంటున్నాను.
Madam, I have one doubt. What happens if you give beta blockade without stabilizing alpha blockade?
Alpha blockade is always followed by beta blockade, sir.
Supposingly, some doctor has given beta blocker without stabilizing with alpha blockade.
May cause a hypertensive crisis, and I think it may precipitate, sir, without alpha blockade. So only if we give beta blockade. And cardiac related issues, in case of cardiac patients, they will precipitate. I think because they may precipitate, sir, with only beta blockade. So combined blockade is the best option as per my opinion.
Precipitate hypertension only or arrhythmias or failure?
Arrhythmias, and they may land into failure, sir. And there are I did not see any cases where they gave only beta blockade without alpha blockade.
Thank you.
Hello? Hello? Hello?
Hello, good morning, madam.
Rohini, yeah, for this cases, it's preoperative and intraoperative management. You said about that, and equally, it's important to monitor and manage them post-operatively as well. Yeah,
Yes, ma'am. Yes, ma'am.
because when you get the infusion pumps ready in theater, you have like a pumps to reduce the blood pressure, and also you have to get the pumps for increasing the BP, because once the tumor is out, all of a sudden they may crash, BP may fall down and very fluctuating, because for long term, like with the problem, they'll have low levels of ACTH.
Yes,
So they don't compensate. So they'll have low blood pressures. You have to maintain the BP to maintain the perfusion because they are used to high blood pressure still now. And suddenly they'll have low blood pressure. So post-operatively, it's important to monitor them. Yeah, and maintain the BP. Thank you.
Yes, ma'am.
Yes, madam, what you said is right. There are like 2 or 3 crucial steps in maintaining this case. One is at the time of intubation and one is at the time of meddling with the actual tumor. And other thing is at the time of the cross clamping. So in the previous earlier 2 situations, there will be hypertensive crisis, and in the later situation, there will be hypertensive crisis, which can lead to which are very important to manage.
So main objectives of pre-op preparation: control BP, reversal of chronic circulatory volume depletion, control of heart rate and arrhythmias, and assessment of optimization of myocardial function, and last and reversal of glucose and electrolyte disturbances.
Yes, ma'am.
Any questions? Two minutes is there.
What is the drug of choice for beta blockade overdosage?
Beta blockade overdose. Calcium. We can
Glucagon.
Glucagon, right?
calcium channel blockage we use.
Beta blocker overdose, drug of choice is glucagon.
Glucagon, madam.
Glucagon, sir. Any questions? Thank you all. Thank you, Rohini.
Thank you, ma'am. Thank you, Ananda.